everybody see that? Can you see that okay? So as Derek mentioned, we're going to do a case presentation as the format. And I'm just going to go that I have no disclosures. In this case is a female walker with lesser metatarsalgia is the case I'm going to present. And I just want to go over the objectives of this whole case series since this is the first one. Again, as Derek mentioned, our overall
Hey Doug.
Yeah?
I don't think we can see your screen. We can just see you.
Okay. So I need to do share screen.
Yep.
Now, do you see it?
Yep, there we go.
Okay.
Perfect.
Sorry about that. So, as mentioned, I'm going to present a case of a female walker with lesser metatarsalgias, no disclosures. And again, the objective of the case, overall case series is as Derek mentioned, to present this in a very practical way through common presenting complaints that you might perform in ultrasound. So specifically, the objectives are review the diagnostic protocols that meet criteria for a complete exam. We're going to go over the protocol images and nuts and bolts of the images, discuss the pertinent pathology, and finally, as Derek mentioned, review the report. Now, what is a complete exam? Well, it's a loose term, and I just put up the AIUM definition of a complete exam, which is typically includes evaluation of joints, synovium, bones, muscle, tendons, sheaths, ligaments, and capsules, etc. In other words, that we are looking at all the pertinent anatomy in the region. It doesn't necessarily have to include the whole joint, or so if the focus is on the medial joint, then all the pertinent anatomy that would relate to the medial joint. So the objectives of this particular case then, and applying those, is review the Forefoot protocol, discuss Forefoot images, discuss the Forefoot pathology that you would see, and then finally review the report. So this case of lesser metatarsalgia is a 56-year-old woman. She's a regular walker, developed increasing pain under the second MTP joint. She had been working with this and tried to modify orthotics, types of shoes without improvement. She actually had to stop her walking program due to the pain. She was referred by the podiatrist for a diagnostic ultrasound to help define the etiology of the lesser metatarsalgia. And I always perform a quick physical exam before starting the ultrasound, and she had mild hammer-toe deformities. She had pain at the second MTP joint with range of motion. She had pain beneath the second MTP joint, as well as pain in the second metatarsal interspace. All right, so just a quick mention of protocols in the region. In our institution, we are very protocol driven. So we have a protocol for an anterior ankle, lateral, medial, posterior and Achilles, plantar hindfoot, and I'm going to present my forefoot. And then it's the ad lib. In other words, someone presents in something that's not common. How do you approach that? Well, all these protocols have in common that I look at joint, ligament, tendon, nerves, and other pertinent anatomy. They all meet criteria for a complete exam, and they also address a differential diagnosis of the presenting complaints. So for example, plantar hindfoot, someone with plantar fasciopathy. Of course, we're going to look at the plantar fascia and other plantar structures, but I also look at the medial tarsal tunnel because that fulfills several purposes. The first is that oftentimes plantar heel pain can come as radiation from the medial tarsal tunnel or can coexist. And secondly, I'm looking at joint, I'm looking at neurovascular structures when I'm looking at the medial tarsal tunnel, again, fulfilling criteria for a complete exam. So what is my protocol for the forefoot? So I divide into dorsal and plantar. And that's for practical reasons. You apply gel, then you wipe it off. And if you're going back and forth, you're going to be doing that a lot and moving the foot around. So I start dorsally and I look at the joints first, as in most protocols. Then I only go to the metatarsals if clinically indicated. So if they're having pain at the metatarsals, I'll look, but that's not part of the standard protocol. Obviously in your athletes, you're more likely to look at these. And then I go to the interspaces dorsally. And then I wipe the gel off and go to the plantar aspect of the foot and look at the plantar plates, interspaces, and fat pad. So let's start with the joints. I do my survey in long axis. And if it's the joint in question, in this case, the second MTP joint, or if there's an abnormality, then I look at the short axis, and ROI is region of interest, and I perform a Doppler imaging. So in this patient, I just want to make a comment that I never perform a forefoot ultrasound without reviewing updated x-rays first. Oftentimes the diagnosis is clearly revealed on radiographs rather than ultrasound. And at the minimum, radiographs are complementary. So we have a standing order in our department that if they don't have updated radiographs in the last 6 months to a year, they automatically get them. So here's the images, and I actually number these images through the protocol just to give you an idea. And forefoot has more images than usual in our protocols just by the nature of it. And I always start with the first MTP joint for several reasons. One is even though the second and third are more commonly part of metatarsalgia, the first MTP joint gives you information. You can have degenerative changes which may alter gait. Oftentimes, it reveals urate deposition in certain cases. So I always do the first MTP joint, and you can see here with the probe and long axis that I'm looking at the joint itself. It's normal, and I move on to the second. And when we get to the second, you can see that the dorsal synovial recess is hypertrophic. And it's synovium, but also capsule. So if it's hypertrophic, it's abnormal. It's also the region of interest. And then I perform Doppler imaging. And notice here you see the skin line because I'm lightening pressure, putting a little more gel on. And so I'm not have a false negative by putting pressure over the structure with Doppler imaging. Also, because this is the abnormal area, I rotate the probe 90 degrees, and I look at the joint in short axis. And this is very important because you will see information in the short axis you won't see in the long axis. So here you see a fair amount of synovial and capsular hypertrophy of the second MTP joint, and I love comparison images. And then I place the Doppler on it as well, lighten the pressure to look for active, what I call synovitis, if you see vessels. And then in this case, I checked the third MTP joint, which you can see is normal. I want to make a couple comments just about the joints. First, a small amount of fluid in the MTP joints is fairly common, and it doesn't necessarily mean pathology. As I already mentioned, you really want to look at the short axis of a joint that is abnormal, or again, the focus of the exam. Capsular or synovial hypertrophy can mimic a Mortons neuroma, and I'll show you why in a second. And then again, copious gel when using Doppler imaging. Several companion cases. This is a 43-year-old runner with second inner space pain. He was referred for a Morton's neuroma injection. And you can see on the long axis image, there's some irregularity of the metatarsal head, synovial hypertrophy, and a little bit of vascularity. But when you rotate the probe 90 degrees, you see the full extent of the capsular hypertrophy, which encroaches on the inner space. And this is why the referring provider was somewhat fooled or thinking that this patient had a neuroma when in fact had problems with the second MTP joint. This could be what Freiberg's may look like, in the later stages as an adult. And again, the comparison image. And then the second companion case is a 56-year-old with rheumatoid arthritis. And here you see that the dorsal synovial recess is thick and very hypoechoic, and this is typical of the synovitis seen with RA. We see hypervascularity, but again, when we look short axis, we reveal the full extent of the synovial hypertrophy. We see erosions and a fair amount of hypervascularity. All right, so we've looked at the joints, and we're going to go to the inner spaces dorsally. I look both dorsally and plantarly. If you're doing a fair amount of forefoot work, you want to be proficient at looking at the inner spaces both dorsally and plantarly. I look at the inner spaces dorsally in the long axis, and if abnormal, I do a dynamic image. So let's just start with the anatomy. And so this is a cross-section, trans of the foot or coronal anatomically. And this is the transverse metatarsal ligament. And so here is a plantar neurovascular bundle. And dorsal to the plantar ligament is the bursa, intermetatarsal bursa. If we look at this in the sagittal plane, we see again the transverse metatarsal ligament. We see the bursa above it and the nerve below it. So this is a normal image of the inner space. I'm pressing up with my thumb. So this is the cortex of my thumb. And we see this ovid hyperechoic structure, and that's the transverse metatarsal ligament. How do I know that? Well, you see as I push up my thumb, it anchors and the nerve wraps around it. on top of it is the bursa, and then you can see the path of the nerve. You don't always see the nerve, but you know where the pathway is. And again, I push up with my thumb when I'm examining these to not only push the nerve up slightly more dorsally, but to splay open the inner space. Sometimes these can be challenging. Sometimes I have to use a smaller footprint probe to adequately view this. And so this is just, again, a companion case of what the abnormal inner space looks like with a neuroma. And you can see as I push up with my thumb, I'm demarcating the path of the nerve, which is thickened, and then you can see above this the bursa. Now in this patient, I looked at the first inner space and was normal. I didn't take a video. The third inner space we'll skip over, also was normal. When we get to the second inner space, and clearly there's an abnormal mass, it's hypoechoic. And of course, then I do dynamic imaging. And this inner space was fairly tight, but I was able to get some dynamic imaging. And you notice in this patient, we really don't see the demarcation between the interdigital neuroma and the bursa itself. And so I now call these, over the last several years, I call these neuroma bursal complexes, because histologically you can't, well, grossly you can't tell the difference between the neuroma and the bursa accurately. And I've had cases where clearly I see a neuroma and it's mostly bursal tissue and vice versa. So I call these a neuroma bursal complex. All right, so that's my exam dorsally. I will wipe off the gel. I'll dorsally flex the ankle so I can get to the plantar aspect of the foot. And I start with the plantar plates. And I survey the plantar plates in long axis. And again, I perform dynamic exams in short axis if abnormal, or again, the region of interest. So just a quick anatomy on the plantar plate. It's fibrocartilage. And the important part is its anchor and thesis to the plantar aspect of the proximal phalanx. Histologically, as it inserts down onto the proximal phalanx to the bone, there's interdigitations. And why that is important is not unusual to see a little hyperechoic triangle at its insertion onto the proximal phalanx. So don't mistake that as pathology. Pathology is usually hypoechoic. And interestingly, pathology typically, but not always, starts laterally for the second and third MTP joints of the plantar plate. So we'll go to our patient, and it's a long axis on the plantar plate, and we see immediately that we have a hypoechoic defect in the plantar plate at its attachment onto the base of it's the lateral condyle of the proximal phalanx. So we go to a dynamic exam where I'm dorsiflexing and plantar flexing the foot. And the reason why we do this is several, to reveal the full extent of the tear. And I just want to show a couple things when we do this, and that is that when we do the dynamic exam, if we see fluid adjacent to the plantar cortex of the proximal phalanx, or on the plantar side of the flexor tendon, that typically is fluid that is leaked out of the joint and confirms the presence of a full thickness tear. So again, because this is abnormal, we go to our short axis images. And on short axis images, you can see here, I just flipped the probe 90 degrees. We see this hypoechoic defect in the plantar plate. So this is the metatarsal head, plantar plate, and this is the flexor tendon. You can see hypoechoic area plantar to that, which partially is a small amount of fluid. Again, confirming the presence of a full thickness tear, and this is the comparison side. Now, what also is very important, as you take the probe and slide proximally to the insertion onto the proximal phalanx. And as we do that, we can see here that there is a significant bony projection with a hypoechoic area around it of some scar or chronic fibrous tissue. This is very important because it can be the sole source of pain in many individuals. And I'll just show that with this companion case. And this is a case from 2 days ago. So I just threw this in at the last minute. And this is a 75-year-old active individual who was referred for a possible third interspace neuroma. And at the third MTP joint, and this is in long axis, and I'm just translating the probe proximally and distally. So here, or I'm sorry, medially and laterally. So this is medial, and I'm going lateral, and we see here there's a defect in the plantar plate and irregularity of bone. And then again, I'm going off and then back on. And we can see laterally the plantar plate tear. Again, when I see this, you need to go short axis and scan to the proximal phalanx. And so in this individual, I'm starting at the metatarsal head, scanning distally to the proximal phalanx, which will now appear. And look what we see. We see this big bony projection. And as soon as my transducer slid over that, he goes, ow, this is the spot. And so we were able to reveal exactly what's going on, again, by making sure you see the full width and the full length of the plantar plate. I'm going to get back to that in a minute. Okay, so now we've evaluated the plantar plates, and we're going to go back to the inner spaces. And this distal anatomy, this is a dissection performed, and luckily this patient had a little neuroma. And again, it kind of reveals how plantar these nerves are. And so what I do is I go back and I start on the plantar plate, and then I'll carefully slide over and I'll get to the inner space, and I'll slide again and back to the plantar plate and back to the inner space. And it's a double check of everything. And so that's what I did in this patient. And we see now the neuroma bursal complex from the plantar view. And when I see that, I will then turn my probe 90 degrees and do a Mulder's test. And here we see that in this patient. And then the last thing that I'll do is look at the fat pad. And this is also very important, often overlooked. And so I'm going to go back to this runner that I saw a couple days ago who had this bony projection at the proximal phalanx. And we see that the fat pad is fairly uniform and hyperechoic. And this is a normal appearing fat pad. For comparison, this is our patient evaluating who has these thickened hypoechoic swirls within the fat pad. And just a little bit of vascularity. And this has been correlated histologically with fat pad fibrosis or scarring. And so this patient had quite a bit. Now, again, it's very important that you correlate this with sonopalpation because people who have hammer-toe deformities, for example, will often develop this, but not necessarily the source of pain. On the other hand, I've seen fat pad abnormalities as a sole source of the metatarsalgia. And just as a companion case, this is someone who had focal fat pad abnormalities here, but had a well-demarcated area, and this is a submetatarsal bursa. And so we see this fibrous collagen bundles here, which is all this hypoechoic stuff with these fibrin-lined papillary projections. We can also see these are commonly asymptomatic under the first and fifth metatarsals. And again, when I see them under the second, they're usually symptomatic, as it was in this companion case. All right, so my findings, second metatarsal joint synovial capsular hypertrophy, second metatarsal interspace neuroma bursal complex, full thickness, incomplete tear. So it wasn't all the way, it was not a full width tear of the plantar plate of the second MTP joint, bony irregularity and fragmentation at the insertion of the plantar plate onto the lateral condyle of the proximal phalanx, and then fat pad fibrosis. I call this second metatarsal syndrome, meaning it's a constellation of problems that occurs. I also see this at the third metatarsal, but more commonly the second. So what does my report look like? All right, so again, there's variability in how we all report this. This is just what I do, and this is the actual report I did. This is a case probably from several years ago. So diagnostic ultrasound, the left forefoot, complete examination. The indications, sometimes I'll put exactly what the referring provider has on there. Sometimes I'll put a little bit of the history. If this person had surgery, I would also probably put what surgery they had on there. I put what probe I use. It's on the ultrasound itself, the images. You don't need to do that. Let's say I was doing a cryoablation of a Mortons neuroma. I would also put on there the device I use and the lot number. And then my findings. And I start off findings with any correlative imaging studies. So in this case, this was radiographs that I correlated. And then again, I just have a template in my mind when I dictate these. Sometimes people actually have a template and they fill in the blanks of the template. You know, there's whatever is easiest for you. I just a little bit old school and I like to have a little prose involved. So in my report, I always mention the first MTP joint, even with lesser metatarsalgia, which is normal. And I Mentioned moderate synovial and capsular hypertrophy without hypervascularity, so there's not active synovitis of the second MTP joint, and the remainder of the MTP joints were normal. And I did actually check all of them. Again, it's dealer's choice whether you want to just go through all the interspaces and go through all the MTP joints, you know, bang, 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 or you only want to do the region of interest and maybe the one to each side. There's a hypoechoic oval-shaped mass within the second metatarsal interspace consistent with the Neuroma bursal complex. The remainder of the interspaces were normal, and then a full thickness incomplete tear of the plantar plate of the second MTP joint associated with cortical irregularity and bony fragmentation, the lateral condyle. Now in that companion case in that runner I saw a couple days ago, I would put down, this correlates with the maximal area of tenderness with sonopalpation. In this case, there was so much going on and symptomatic from the neuroma, from the plantar plate tear, from the fat pad. I didn't put that, but I often will put, especially with metatarsalgia, where the maximal area was with sonopalpation, because asymptomatic neuromas, asymptomatic fat pad changes are common. And then I mentioned diffuse hypoechoic thickening of the fat pad. And then in my conclusions, pretty much what I've said all along. So that's the report for this and how I do the report. All right, so in metatarsalgia, we've had failed, this patient, this follow-up, failed multiple attempts at shoe and orthotic modifications. This patient eventually underwent surgery and did very well. It took a while, but it's 5 months, she was back to normal activity. So take-home points: review radiographs prior to starting your sonographic evaluation, protocol-driven exams to meet the criteria for a complete exam, even though it's somewhat of a loose criteria, and address common pathology and differential diagnosis. Correlate findings with clinical and sonopalpatory information. In my experience is ultrasound is just fantastic for metatarsalgia. It's rare that I don't find a cause. It's rare that I get information on an MR that I don't get on an ultrasound, but it's not uncommon for me to see pathology on an ultrasound that I would not see on MR. So it's an exam it's worth being proficient in. It's not really that hard once you get used to it, and it's the first line advanced imaging in our institution for metatarsalgia. All right, so we'll stop there and take any questions, discussions, thoughts, how other people do this. Any questions? We're going to post this on the Collaborate, and so at any point you can go back and see this, or obviously for those of you who are on from the West Coast and up bright and early, you may choose not to do that each time, and you can go back and on the also the YouTube channel of AMSSM and see these. Well, it's 8 o'clock, and then we'll stop there, and the next one is in 2 weeks. Derek will be doing a shoulder case, and we're going to be trying to do these twice a month, and just again try to pick fairly common cases, and hopefully we'll build a fairly strong library. We also hope after the first of the year to get fellows involved after they've got a little bit of experience under their belts as well. So have a good Friday, everybody.